to the hit podcast, H.I.T, Human Resources, Insurance, and Technology. I'm your host, Toby Kennedy. Last week, we went a little long with our fantastic conversation with John Montague. Today, we're getting into part 2 of 3. If you missed last week, go back and check it out. This will be part 2, and we'll wrap it up next week. And without any further ado, this week's episode is brought to you by Montage Insurance Solutions. And let's pick up our conversation where we left off.
I want people to drill in that that's where we are in the conversation, and that's what we've sort of established thus far. But you were just about to say, but there's some magic to it. There's something different to it. It's not just a copay plan. That's not why we all leapt out of bed today. There's some magic.
I mean, the magic is that it's a dynamic copay model. It's a variable copay model. And what we've done is we've said, you know what? Other health plan designs, you're pretty much subsidizing care at the same levels across the board. So maybe everything's 20/80. Your plan's covering 20, the plan's covering 80, the member's covering 20 in that coinsurance model, and then the member's getting over the deductible. We said, let's get rid of those things. And our members don't look at a copay as a copay. They look at it as their cost.
Yeah.
It's a price tag. It's their total responsibility for care.
It, by the way, is how they buy everything else in their world.
Exactly. And that was the goal, is how do we deliver something that is similar to everything else that we consume, in our big global economy. And really that dynamic copay model and how it works, quite simply, is we run data analytics on all of your different care options. And it's important to understand that this isn't about a narrow network. This isn't about taking people's choice away. This is using the broadest national quality-based network in the industry, United Healthcare's Choice Plus, Select Plus network. So it's about giving our members as much choice as possible, but then giving them the tools and the information to make better choices, and to give them a health plan design that essentially incents them, motivates them, rewards them for being better healthcare consumers, for helping reduce all that wasteful spending by making better choices, just like they do when they shop for groceries, for cars, for homes.
Choices on the provider level, to be specific, not within their own life. So this isn't something where we say, hey, you get on the scale now, you get on the scale 6 months later. If you made the right dietary choices, you have a lower copay. We're talking about a plan where we get rid of deductibles, we get rid of coinsurance, we back it with the largest provider network, the United Healthcare's full network. So we're not stripping down any providers, but we're saying to people, you're going to have copays per episode, and the copay that you spend, the steerage comes in, it will vary based upon the provider you choose. Is that right?
Yeah, and the type of care. I'll give you a couple examples. So if you're looking to go to the doctor, well, we're going to run data analytics on every single doctor. So if you're looking for a specialist, let's say a dermatologist, we're going to show you every single dermatologist that's in network in your area. And then we're going to essentially rank all of them according to their performance, their efficiency, and their effectiveness. And we're going to assign copays to all of them that reflect the value of the care that they're delivering. And really what it's about is helping steer our members away from the waste.
Yeah.
And what we find is that when you run these analytics, 80% of the providers are doing a great job.
Yep.
They're considered high value providers. 10%, maybe their quality information or their cost information doesn't look great. So I'd put them kind of in that medium bucket. But it's really that 10% of the providers that are driving all the waste, that have bad cost data, they have bad quality, efficiency, effectiveness data. And it's about identifying those kind of bad actors, the providers that are not doing a good job, and jacking their copays up high to help steer members to the high value, high quality providers with the lower copays. And the way you do that is, the greatest motivator, which is the wallet, the pocketbook. When a member can save $50 out of pocket by going to this very good doctor instead of going to this high waste doctor, when they can save sometimes thousands of dollars by going to this place to have their knee surgery versus that place, that's what we're finding is the way that you can help curb all that wasteful spending. It's just through basic plan design where we subsidize the higher value care at a higher level and we subsidize the lower value care at a lower level. So if you want to make bad choices, you can, but you're going to have to pay more out of pocket.
Meaning I specifically want to go to this doctor because I've been going to him for a long time. I really like him and he's in network. Now I do want to drill down on this a little bit because if we don't, it can seem like big bad uncle, really putting finger on the scale. And so when you say you're objectively deciding which doctors you're going to steer to via the kind of dynamic copays. So you want to go to Dr. X, that's fine. It'll be a $10 copay. You want to go to Dr. Y, you can if you want, but that's going to be an $80 copay or a $60 copay or whatever, right? So when the member just pulls up on his or her app and says, I want to see a dermatologist, they're going to get a list of doctors with flat, fixed copays beside them. And those copays will vary where you're steering people to higher performing doctors away from lower performing. Can you give me a little bit more information about who you're steering to and away from, how doctors get ranking, et cetera?
Keep in mind that the vast majority of our members are using the mobile app on their phone as their primary tool to navigate the plan, to navigate their healthcare. They can also use a website, very easy to use website, or they can call in and talk to somebody live on our helplines. But basically, think of that member experience as searching for something on Google, shopping for something on Amazon.
It almost looked to me like simple. Uber too, where like you pull up the Uber, you have the choice of Uber X, Uber Black, Uber this, Uber that, right?
Yeah.
And it shows you on the map all the different cars. So I can look on the map and you've got these little dots that one says, $60 for my drive, one says $40 for my drive, right? When I looked at your app, it looked a lot like that, where I got to see a map and I got to see the little dots where the providers were and who's accepting and a little copay right there. And then on the side, you can see the list of the doctor and what they're good at.
Yeah. And it's just all about making it easy and making it easy for people to find, again, the right care at the right place, at the right time, at the right cost. And it's really important to point out that the plan was built so that it's not only about guiding you to the right doctor. When you need help with a particular condition or symptom, getting you to the very best doctor that can treat that condition in the most effective and efficient way. But it's also about sometimes helping guide you to a different type of treatment, a different care option, because
meaning physical therapy before knee surgery sort of a thing?
Exactly. Physical therapy instead of a major procedure. I just had an experience very similar myself where by using our tools, I had a hockey injury. I was going down the orthopedic path. I was under the understanding that I was, a great candidate to have a surgery that ultimately would have been very risky, very high cost. And the data, isn't real good about the efficacy of this particular fusion surgery that I was considering. But by using our tools, I was able to find some really helpful information about acupuncture. And ultimately, I was guided to getting an injection to get the inflammation down, then doing a regimen of physical therapy to help build the strength up, and then ultimately mixing in some acupuncture. And I'm happy to say that after 2 months of what you'd call alternative care options, I was able to avoid that very risky and costly surgery.
I have a similar story.
I haven't had any problems for 2 years.
Yeah, I had a pop in my knee. I got the MRI done and it was a partially torn ACL. And they recommended me for surgery. But before surgery, I needed to do not rehab, but they call it prehab. I needed to build up my strength so that after the surgery, my leg, my muscles around it would be strong enough. A couple months of prehab later, I was like, honestly, I can do everything I need to do. This prehab did so much strengthening for all my area around. I don't want the surgery. I never did the surgery and I've been fine ever since. So it's interesting how sometimes, if we can do a little bit of, like you're saying, an alternative care, but we are right now on this path of alternative care versus surgery. We're unpacking a little bit about some of the steerage, but I don't want to lose sight of, how are we identifying doctors that we're steering away from? Like, what's going into that would make a consumer, an HR director that might buy this plan, feel good about who you're steering my members to and away from, right? I don't, because it gets a little intimate when you're telling people who to see.
Yeah, I mean, trust me, I used to work with Mayo Clinic, where there's a lot of sensitivity around what you would talk about as the value of care, the total cost of care, versus perhaps what contracted rates are. And I also am in a family with a number of physicians, and so this is a very sensitive topic when you talk about how are you rating providers, in terms of their performance, their quality, their efficiency, their effectiveness. And what I can tell you is there's probably no perfect way to do it. There's always going to be discrepancies. But I can tell you that before we were a health plan, we were a technology company. We were a data analytics, a data science company. And there has been a significant amount of work put into the algorithms and the engines that we've built to run these analytics. But it all starts with claims data. So we're looking at billions and billions of the United Healthcare claims data. We're cross-referencing that with the IBM Watson Truven Health data, Clarify claims data, CMS. There's a lot of different claims resources out there, but it's about looking at these billions and billions of claims files to look at a given claim and to say, is Dr. X performing many more procedures than what the guidelines say are normal? Is Dr. Y have bad referral patterns based on what we're seeing with different costs and quality measures with the people in their referral paths? What are the outcomes that are being delivered? Is Dr. Z have a good history of getting people off of the medications that they've been taking to treat a given problem? What are their rates of going back in for similar procedures and treatments within a 3 to 5 year period after this episode of care? It's looking at that long tail of data as well to say not only what were the costs that were charged and all the different services that were encompassed in a given episode of care, but then look at what are the outcomes that are being delivered. And a great example is I mentioned Mayo Clinic, and I think Mayo Clinic is really an excellent example to hit home on this point of the value of care and the total cost of care versus maybe just the costs that we've all been trained to think about, well, what are the contracted rates? Looking at CPT codes, just looking at it very much as a basic cost. At Mayo Clinic, they would say that they're often being called out as a, quote, high cost provider if you're just looking at contracted rates. But at Mayo Clinic, they would say, we're not high cost, we're high value. We're high quality because we're getting people out of the hospital earlier. We're getting people off their prescription drugs. We're reversing type 2 diabetes. We're not just treating it. We're making populations healthier, so we're avoiding more of the high claims, more of the chronic conditions, more of the other things that are really driving costs in the system. And so it's looking at cost differently. And I'd say that's what we do from an analytics side of things, is we really look at the total cost and the total value of care.
I love that. And I love that you're talking about the multiple places you're ingesting claims info from, the billions of points. One that was brought up when we were in the room together last week was the same provider of care, and someone was talking about having a colon removed. The same hospital where Dr. A had like a 5 to 7% infection rate after that event, and Dr. B in the same hospital had a 45% infection rate after that event. So you're starting to see, again, with some of this transparency, that providers of care have a discrepancy. Or even one thing that COVID really brought about, I have a buddy who's an orthopedic surgeon. He said that for this procedure, Toby, we used to have people in for 3 days. And with COVID, we had to get them out. We didn't have the beds. turns out we can do this outpatient, right? So necessity was the mother of invention there, but keeping someone in a hospital for 3 days when now it turns out best practices don't, right? Let's just do it at a freestanding clinic. We don't even need to do this at a hospital site. Get them in, get them out, get them home. And infection rates are way lower. Or like when you're talking about overall arc of this episode, I think is such a great word, because if what we can do is try to steer, like you said, to those physicians that are engaging in best practices, because that's kind of how they do things, you wind up having a lot lower costs. And I do want to touch on that a little bit, because I think you guys are, I don't know, 7 years into the pilot or something like that. And you have some data on the costs here, which, I mean, I hate to be this deep into the conversation, really bury the headline, but my goodness, my eyes popped.
Yeah, I mean, I think at this point, we are 7 years in. So, we came into the market back in 2016, started serving clients in 2017. So here we are 7 years later. And I remember when we first came into the market, what we heard over and over again was, this is too good to be true. You're telling us that you're going to provide a better benefit and you're going to reduce costs, and you're not just going to reduce costs for the employer, but you're going to significantly reduce costs for their employees too. This isn't a cost shift. And so we kept hearing, this is too good to be true. I'm going to wait and see. It kind of went against the conventional thinking in the industry of, well, if you're going to bring costs down, then you've got to bring the value of the benefit down, or you got to shift the cost from the employer to the employees, or you need to take away choice with a narrow network concept, et cetera, et cetera. So it went against the thinking everybody had been trained on with these other products. And we came in and said, no, we believe that by significantly reducing the wasteful spending and driving more consumerism, we believe that we can take enough cost out of it that not only can the plan and the employer save a lot of money, but the employees, the members, can save a lot of money, and we can deliver a better benefit. So fast forward, we're now 7 years into it. And those people that said it's too good to be true, they kind of waited on the sidelines with a wait and see. They're now all realizing that, no, we've been delivering very significant, consistent results for 7 straight years. We have a book of business now that includes many, many Fortune 500 household name clients. We have the highest net promoter score of any health plan in the industry. We've had among the highest, client retention, member retention rates, every data point you would look at to say, is this indeed working? Is it truly too good to be true? The answers have been absolutely, this is working. And on average, over this 7-year period, we've been delivering between 10 and 15% savings to the employers on a given year against the benchmarks. And we've been delivering about 50% savings to the members, to the employees, out of pocket year over year.
I want to pause on that because it's so profound. So what you're telling me is you guys have brought forth a plan that has no deductibles, no coinsurance, does not narrow the network of providers, is running 10 to 15% below for employers on the premium standpoint, and the member experience for the same episodes of claims is 50, half off, 50% reduction in what members had experienced when they would have gone through these same claims with deductibles, coinsurance, the normal plan designs. What the members are paying is half.
Exactly right. And, all the points of the thesis when this company started have been proven to be true.
That's all the time we have for you here today. Sticking to our commitment to keeping the episodes bite-sized in length, we will wrap up our conversation next week. Thank you to our sponsors, True Hue, and join us next week. And until next week, make this the best week yet.